Um, So I hope you guys are well. We can start. So an 18-year-old boy presented with yellowing of the eyes, fatigue, and loss of appetite. He says he went camping and had not eaten for at least 48 hours. His liver function tests are normal, and he has no history of liver disease. Lab tests show increased concentration of unconjugated bilirubin. Identify the most likely diagnosis, giving reasons. So, yeah. Remember we talked about causes of unconjugated bilirubin. So from those causes, which one do you think is the most likely diagnosis for this 18-year-old boy? Hemolysis. Okay, yes, that's a very broad term. Hemolysis might have caused the rise in unconjugated bilirubin, but like if you were to point out what is the exact cause, I'm seeing someone saying malaria. Malaria. Malaria can be a diagnosis, but do we know the yeah, malaria can be a differential. But remember, this is clean chem. Malaria is more of another part of hematology, sorry. Yeah. Plus, also look at the time frame. Does malaria present in like 48 hours? 2 days. The incubation period of malaria is usually around 1 week to a month. Yeah. So can give you a hint. Remember when we talked about causes of unconjugated bilirubin, we mentioned these ones: biliary atresia, hemolytic disease of the newborn, Crigler-Najjar syndrome, Gilbert syndrome. Those ones are the causes of unconjugated. So I can give you a hint. Out of 1, 2, 3, 4, out of these 4, what can be the diagnosis for this patient? Biliary atresia, look at the age. The person is 18 years old. Remember we said biliary atresia is for pediatrics. Hepatitis. For hepatitis, we'll expect LFTs. You can see in this patient the LFTs are normal. For hepatitis, we'll expect AST and ALT to be raised. Yeah, so with that will eliminate hepatitis. Gilbert, because of stress-induced. Exactly. Yeah. So the diagnosis is Gilbert disease. Remember when we talked about Gilbert, we talked about Gilbert syndrome being a mild reduction in UDP. If I can go to this picture, let me expand. I can go here. Look at this unconjugated bilirubin to conjugated bilirubin. Now, this enzyme, UDP glucurosinyl transferase, is now the enzyme that is affected in Gilbert syndrome. Where we said Gilbert syndrome is where you have a mild reduction in this. And then for Crigler-Najjar, we said that this is absent. So this can't be Crigler-Najjar. Okay. Yeah, so the best diagnosis is Gilbert. Let's see. Okay. So most likely diagnosis, Gilbert. Reasons. So the first reason, adolescent onset. So the kid is 18 years old. The second reason, he has normal liver function tests and has no history of liver disease, showing that the condition was caused by a triggering factor. The triggering factor was the prolonged fasting. You can see here it's saying he had not eaten for 48 hours. There were increased levels of unconjugated bilirubin, which is caused by a mild decrease in UDP, glucosinyl transferase, or UGT. Okay, I hope this is clear. So the main thing you have to see here is the LFTs are normal here. The LFTs are normal. If you see normal LFTs, think of something, the prehepatic jaundice, and of which we said, yeah, the causes. I think we had gone through that. Okay. I hope that's clear. Okay. How does biliary atresia cause unconjugated bilirubin? Sorry, did I mention that? Biliary atresia causes direct bilirubin or the conjugated bilirubin to be raised, not the unconjugated. Kindly go through the causes again. Okay, I can go through the causes quite fast. Causes of conjugated and unconjugated bilirubin. So we start with biliary atresia. For biliary atresia, we said that this is the most common cause of pediatric liver transplant. Okay, so what happens is you have the destruction of the bile ducts. Okay, so biliary atresia, so they are absent. Now what happens is you'll have increased direct bilirubin, and usually the enzyme elevated is GGT for biliary atresia. Okay, for hemolytic disease of the newborn, this one we know will have increased unconjugated bilirubin because hemolysis is occurring within the blood vessels. For Crigler-Najjar, as I've mentioned, you'll have complete absence of the UGT, that the enzyme. Gilbert, mild absence. Then the Dubin-Johnson, we said the difference between Dubin-Johnson and Rotter syndrome, we check the color of the liver. So the color of the liver in an autopsy, this one will be dark. So remember, Dubin-Johnson, a dark liver. Rotter, it will be a regular colored liver. But here you'll have an increase in conjugated bilirubin for both. Okay. Basically, there's a problem with excretion in these two. Okay. I hope that's clear. We can continue. So here are some cases. Here are some cases. Let me make it smaller. Okay. Okay. I want you guys to help me. A 1-month-old baby. Total bilirubin is 490. Direct bilirubin is 9.5. Urea is 12.5. So what is this case for case 1? You tell me the diagnosis. Not even the diagnosis. Interpret for me. So is it unconjugated bilirubemia, conjugated, or mixed? So answers in the chat. Unconjugated bilirubemia. Excellent. 2-week-old baby. 2-week-old baby. 385, 318. Conjugated, yeah. So you'd be given a chart like this, then you'll be told to interpret. And if you're asked, you'll say, so you'll be given a chart like this, then you're told to interpret. Then you'll be told list likely causes, of which we have gone through them. Then for these two, I want us to come back to them after I've explained all about the AST and the ALT and the LK, GGT, and the albumin. Okay, so remind me to come back to these two. Okay. Okay. Now I want us to interpret this. We're now going to the bulk. Okay. A 28-year-old woman is found to be having the following liver function tests as part of the routine health check. Albumin, 40, which is normal. Bilirubin, 37, which is elevated. AST, 144, which is quite elevated. LT, 260, which is quite elevated. And ALP is normal. So when answering these questions, I want to give you a formula what you use. And I want you guys to use this formula for each and every LFT you get. Okay, really, really helpful. So the first thing you check is interpret the values. So normal, elevated, normal, or decreased. Then the next thing you check is check the AST to ALT ratio. Notice I have not said ALT to AST. I've said AST to ALT. Okay, there's a reason I've said that. We are using that ratio. Don't confuse yourself. Okay. So for here, when you check the AST to ALT ratio, 144 over 260, it's less than 1, isn't it? 144 is less than 1. Okay. Now, for the interpretation, this is the template I want you to use. So remember, in liver injury, we have acute liver injury and chronic liver injury. Can someone differentiate for us in the chat? What's the difference between acute liver injury or chronic liver injury? I think this one we have mentioned quite a lot. You guys should be knowing it. What's the difference? Like, what is it? Acute within 6 months. So greater, sorry, less than or equal to 6 months, acute, and then chronic. Less than or equal to, and then chronic is greater than 6 months, isn't it? And what about fulminant and subfulminant? How do we define fulminant liver failure? Fulminant, we said, is within 2 weeks. Excellent. Subfulminant? Subfulminant. Less than 3 months or within 3 months. Yes. Okay. I'm seeing someone is asking, how is it less than 1? 144 is 260. Okay. So a ratio, what is a ratio? You divide something. There's a top and a bottom. For the top, it's 144. For the bottom is 260. If you do 144 divided by 260, it will be 0 point something. Isn't that less than 1? So I hope I've answered your question. So it's less than 1, isn't it? Okay. So if acute, so if this patient presented acutely, our diagnosis will be viral hepatitis. So the first thing you do is you check for the surface markers of hepatitis, okay? If chronic, so if this patient presented with the following the LFTs greater than 6 months, our first diagnosis will be, so we'll have non-alcoholic fatty liver disease, or you'll see it's been shortened as NAFLD, viral hepatitis, so hepatitis C, hepatitis B, drug-induced hepatitis, Wilson's disease, hemochromatosis, autoimmune hepatitis. Okay. I'm sure you've come across these Wilson's disease, hemochromatosis, and autoimmune hepatitis. Okay. So I hope that's clear. You check the ratio first. Then, if it's less than 1, if it's an acute injury, it's viral hepatitis. It's a chronic injury, non-alcoholic fatty liver disease, viral hepatitis, drug-induced hepatitis, Wilson's disease, hemochromatosis, and autoimmune hepatitis. Okay. I think that's okay. Now, for a 32-year-old. So a 32-year-old patient presented with the following: a bilirubin of 21, which is elevated, albumin normal, total protein normal, PT, prothrombin time, 30, which is quite elevated. So in blue, liver damage results in decreased formation of clotting factors, hence prolonged prothrombin. ALT 132, AST 320. They're both elevated. LP 98. So you check at the AST-ALT ratio, which is greater than 1 here. So if it's greater than 1, if it's an acute injury, diagnosis would be alcohol-induced liver cirrhosis, liver ischemia, drug toxicity, e.g. paracetamol. And then if it is a chronic injury, alcohol-induced liver cirrhosis. I hope you've seen that. Okay. The most important thing for you to remember that you must never forget is, if the AST-ALT is less than 1, the first thing that should come to your mind is viral hepatitis. Because you'll notice, even if it's an acute injury and a chronic injury, viral hepatitis is still there. The next thing, if the AST-ALT ratio is greater than 1, if it's an acute or a chronic injury, you think of alcohol-induced liver cirrhosis. Okay? Think of that. Okay? So if you just see an AST-ALT ratio greater than 1, think of alcohol-induced liver cirrhosis. ALT-AST ratio less than 1, viral hepatitis. That would be the best thing. And that's the most high thing you should know on interpreting these LFTs. Okay? Any question there before I give you some tips here? No question. Okay. These are high points I want you to keep. Patient presents jaundice, anemia, and increased unconjugated bilirubin, and everything is okay. When I say everything is okay, I mean that all the LFTs, if they're done, they're normal. Diagnostics, hemolytic, prehepatic, jaundice. So if they ask differentials, so you know, you'll mention them as we mentioned above there, okay? And number 2, patient with jaundice, increased unconjugated and conjugated bilirubin, increased AST and ALT levels, increased stroke normal ALT diagnosis. What do you think this is for number 2? What do you think this is? Which jaundice is it? Hepatic jaundice, excellent. Or hepatocellular. Hepatocellular stroke, hepatic jaundice, good. Number 3. Patient with jaundice, increased unconjugated and conjugated, but for the conjugated, it is markedly increased bilirubin levels, increased mildly AST or ALT levels, but markedly increased ALT and GGT levels. What do you think this is? Which type of jaundice? Post-hepatic, yes. Yeah, now post-hepatic. The last bit should be markedly LP and oh yeah, sorry. I've written LP. Thank you for the correction. Yeah, alkaline phosphatase. Markedly increased LP and GGT. So it is a post-hepatic jaundice. Yeah. So basically we are dealing with disorders of maybe the gallbladder, the biliary tree. I think we had discussed this, so that's okay. Obstructive stroke, post-hepatic jaundice. Yeah, that's okay. And then this one, patient presents with epigastric pain radiating to the back, fever, increase in amylase and lipase levels. What's that diagnosis? Pancreatitis. Excellent. Pancreatitis. So, acute pancreatitis. Now, I have a question for you here before we finish the ALTs. So, what happens if we have a high ALP? Listen to this. A high ALP and a normal GGT, and then the rest are normal. Okay. Yeah. Maybe the only derangement is you have a high ALP, but a normal GGT. What will you think of? What will you think of? Let's see answers. Cholangitis, no. For cholangitis, they'll still be increased. And I think Noella took you through where you have markedly increased ALP. Bone issues, excellent. Bone damage, yes. And because we said ALP is also produced in the bone. So if you check your ALP is raised, but the GGT levels are normal, think about bone damage. Yes, so maybe the question came, the patient had an accident and the ALP was raised. That's how it came. So think of bone damage, okay? I think that's okay. Which other one can I think of? Yeah, I think for the LFTs, I've given you the formula of interpreting. We started along with, I was to tell you, we come back to this table. Yeah, let's go back. Okay. Blue for this 69-year-old. 69-year-old male. Here are the results. LT is 183, ST is 152, LP is 820, GGT is 1194. Let's interpret this for this 69-year-old male. What does the 69-year-old male have? Post-hepatic jaundice, maybe gallstone, osteoporosis. I don't know. Are you asking osteoporosis? So choice C. Choice C, he has post-hepatic pancreatic cancer. What number are you in? This 69-year-old male. Okay, so we can tell here that it's post-hepatic jaundice. So think of the causes of post-hepatic jaundice. Oh, pancreatic cancer. Yeah, so pancreatic cancer can be a differential. So, okay, I just wanted you to mention the type of jaundice. So, differential for post-hepatic jaundice, we have a lot: pancreatic cancer, liver cancer, gallstones. You remember when we talked about primary sclerosing cholangitis? What else can you think about? You know, gallbladder cancer, all those. Okay. And then for the 77-year-old, 77-year-old. What about the 77-year-old? So let me see the chart. Liver cirrhosis. Okay, yes, liver. But okay, which type of jaundice is this? So we said we check the jaundice first, then we check the AST-LT ratio. Look at the AST-LT ratio. Is it less than 1 or is it greater than 1? The AST-LT ratio is 34 divided by 75 is less than 1. So what did I tell you? Post-hepatic? Post-hepatic, I'm seeing the LP and the GGT are normal. The GGT and the LP are normal. Yeah, so it can't be post-hepatic. So viral hepatitis if acute. Yeah, so most likely it's a hepatic jaundice. Yes, a hepatic jaundice. And he was trying to, he was. So yeah, we have. So this is most likely a viral hepatitis, isn't it? We said if it's acute. Yeah. Does the ST-LT ratio still count when if one of them is normal? Yes. So always be using the ST-LT ratio. Okay. Let me go through it again. Someone has told me they have not understood. Okay. Let's start with this one. Let's start with this. A 28-year-old was found to have the following LFTs. Albumin is normal. Bilirubin is 37, which is elevated. AST is elevated. LT is elevated. LP is normal, isn't it? So I told you, you look at the AST-LT ratio, which is 144 divided by 260. if you are to do that math, let me do it. It's actually 0.55, which is less than 1. So if I said if it's less than 1, if it's an acute liver injury, we diagnose viral hepatitis. That's our differential. If it's a chronic injury, we think of non-alcoholic fatty liver disease, viral hepatitis, drug-induced hepatitis, Wilson's disease, hemochromatosis, and autoimmune hepatitis. Okay. And then we went to this other patient. We saw our ST-LT ratio was, ST was 320, LT was 132. It comes to 2.42, which is greater than 1. If it's an acute injury, think of alcohol-induced liver cirrhosis. And then, or liver ischemia or drug toxicity, e.g. paracetamol poisoning. If it's chronic, think of alcohol-induced liver cirrhosis. Okay. Yeah, so I've explained for the ratios. And then for the pre and post hepatic, this is something we had done. We said if the types of jaundice, if let me count this picture. If hemolysis occurs here and you have increased unconjugated bilirubin, we'll expect to have increased unconjugated bilirubin. Now that is what we call it pre-hepatic, because it has occurred before getting to the liver, okay, in the blood vessels. If jaundice occurs here inside the liver, and we have an increased rate of conjugated, both conjugated and unconjugated, we'll call that hepatic jaundice. And if there's a problem with delivery here in the gallbladder, you'll have increased unconjugated and normal conjugated. Now that is post-hepatic jaundice. Understood? So we go back to our chart. Okay. I hope I've understood. So how are we getting that from the chart? Okay. From this chart, what is direct bilirubin? Direct bilirubin is basically conjugated bilirubin. So if conjugated bilirubin, let's start with this 1-month-old baby, 9.5, and total bilirubin is 480. To get the unconjugated bilirubin, we just minus these two, and you'll see that one is elevated. And we said the answer of the 1-month-old baby said increased unconjugated bilirubin or unconjugated hyperbilirubinemia. For this other one, the direct is more, so direct, so that is direct hyperbilirubinemia. For this 69-year-old, look at the bilirubin. The direct is mostly affected. The direct is the conjugated bilirubin is mostly affected. And then also look at the ALP and the GGT. As we said, ALP and GGT, when they're highly elevated, think of post-hepatic. So this one has a post-hepatic jaundice, and we said the differentials, we mentioned them. You know, pancreatic cancer, gallbladder cancer, cholelithiasis, the gallstones, primary sclerosing cholangitis. And then for this 75-year-old man, sorry, 77-year-old male, look at the bilirubin. Which one is most elevated? Direct, isn't it? Which is 106. And then look at the GGT and the ALP are normal. So look at the ST-LT ratio. Will be less than 1. And we said for less than 1, if acute viral hepatitis, if chronic, these are the answers. So is that clear? Is that clear with the lefties? So can you continue? Someone was asking, why is it acute pancreatitis? So for pancreatitis, if you check, chronic pancreatitis, normally the amylase and the lipase levels will not most likely be raised. So if you just see increase in amylase and lipase levels and epigastric pain radiating to the back, so you know this is a pancreatitis. And because there's an increase in these levels, it's acute. Okay, let's go to lipid profile. A 58-year-old man came to the casualty with intermittent chest pains. The doctor on call requested a lipid profile to be done, and the following are the results of the lipid profile. Total cholesterol 12.8, so this is elevated. Triglycerides 2.3, which is normal. HDL cholesterol 0.92, which is low. His blood pressure was 145, so he's hypertensive. He was obese with central fat distribution. Can you make a provisional diagnosis based on this? So what do you think the diagnosis of this 58-year-old man is? So chest pain. So can give you some hints. We have intermittent chest pain and hypertension. So can you make a diagnosis? Answers in the chat. A diagnosis for this patient? Myocardial infarction, maybe due to atherosclerotic plaque blocking the coronary artery. Excellent. Perfect. So we have a myocardial infarction, evidenced by the chest pain. And look at the HDL. HDL, which is actually the good cholesterol, is very low. And then the total cholesterol is way, way, way high. So meaning that there was a plaque. And for the plaque here, since it's a myocardial infarction, we know that the plaque is blocking the coronary artery, isn't it? Yes. And plus the patient is also hypertensive and is obese with central fat distribution. So let's see the answer. This is most likely an acute myocardial infarction from underlying coronary artery disease. The patient has a characteristic chest pain and the presence of risk factor which would have led to coronary artery disease, which include hypertension, central obesity, and hyperlipidemia. Okay. So if you just ask the diagnosis, you can just mention an AMI from an underlying CAD. That's enough. Okay. Yeah. Is it possible to get the LDL-CL levels using the values given? So yes. So the question is asking calculate the LDL. Here are the values. So can someone calculate? Give me the answer. Any answer? $11.88. Any other answer? 10.8. Yeah. So 10.88. Yeah. So the formula, hopefully you know the formula. So total cholesterol is equals to LDL plus HDL plus triglycerides divided by 2.2. We divide by 2.2 if the values are in millimoles per liter. And then we divide by 5 if the values are in milligrams per deciliter. But we don't use milligrams per deciliter in Kenya. That is a US value. Our values are millimoles per liter. So we divide by 2.2. So by simple arithmetic, when you divide, you get 10.88. Yeah, that's where you get it. So I hope that one's clear. 3 treatment options for this patient. This one, I think we have done it, so it's going to be quick. Answers in the chat. Statins, yes, for the hyperlipidemia. Nitroglycerin for the chest pain, yes. Think of non-pharmacological treatments. So we have change in diet, weight reduction, so via exercises, then antihypertensive medications. Does he have a history of smoking? So this patient does not, but in case they had an history of smoking, so quitting smoking, we have quitting alcohol, exercise. Yeah, they're quite a lot. Okay, I think that's clear. Okay, a 64-year-old truck driver was seen in our outpatient clinic and the lab test requested. His lipid profile is shown below. Total cholesterol is 12, which is high. Triglyceride is 2.2, which is normal. HDL cholesterol is 0.8, which is low. Fasting blood sugar 11.8, so this is a diabetic. Then gamma GT is 219, which is 0 to 30, which is very elevated. A non-smoker with blood pressure was 140, years obese and central fat distribution. Cause, so for here, we can see the hyperlipidemia because of the total cholesterol, and it is secondary to the diabetes. Okay, so this is secondary hyperlipidemia, and this one was primary. Okay, cause, how does type 2 diabetes cause fatty liver? So gamma GT may be raised due to non-alcoholic fatty liver disease. When glucose levels are elevated in the context of prediabetes, this provides substrate for triglyceride synthesis. Additionally, impaired VLDL secretion, which commonly occurs with insulin resistance, further contributes to hepatic fat accumulation. So those are the 2 ways. So we've seen 1, elevated glucose levels form a substrate for triglyceride synthesis. And then number 2, impaired VLDL secretion occurs with insulin resistance, contributes to hepatic fat accumulation, leading to the non-alcoholic fatty liver disease. Okay. Yeah, so those are 2 ways. I think I can separate them. Yeah. So I think that's okay. Then give a diagnosis. Is this guy hypertensive? Yeah, he's hypertensive. Oh, sorry, this question. They're separate questions, sorry. Just There are two separate questions. Sorry, that's why it wasn't making sense. Yeah, this is for this. This is for this. Okay. So a non-smoker, his blood pressure 140/90. He has central fat distribution. Diagnosis, hypercholesterolemia, secondary to diabetes mellitus. Stage 1 hypertension with central obesity. Diabetes mellitus. Or is it the same question? I'm actually very confused. I think I'm confused. Wait, I'll correct the slides when I'm sending, but I think you get the point. If you see diabetes and high cholesterol, it is hyperlipidemia secondary to diabetes. Okay. Which other additional information will you collect from this patient? From this patient? Which other information will you collect? So answers in the chat. When I mean additional information, you can also mention the lab tests. Smoking history. So smoking history is under lifestyle, isn't it? So you'll inquire about the lifestyle history. So if the patient smokes, if they drink alcohol, you know, if they exercise a lot. What else? Yeah, the diet. Yeah, you can ask about the diet. So for the tests, creatinine and urea. So that's a kidney function test. Okay, so why do creatinine and urea? So we want to know the function of the kidney. So let's try and relate it based on this diabetic. So think of, in order to answer this question, think of what can develop in a patient with diabetes or complications of diabetes and hyperlipidemia. HbA1c. Yeah, yes. LFTs, yes. LFTs. Cardiac enzymes. So cardiac enzymes. So why the cardiac enzymes? What are you thinking? Any other answers? So family history, yes. You should inquire for family history if they have a family history of hyperlipidemia or diabetes. So medical history, determine if the patient has pre-existing medical history such as diabetes and cardiovascular disease, kidney disease that may contribute to hypertension. Liver function tests to rule out coexisting liver disease that may be aggravated by medication the patient may be put on, e.g. statins have an effect on LFTs. Kidney function tests, urine microalbumin test to assess if the patient could have developed diabetic nephropathy. So this is what I wanted to remember. One of the complications of diabetes is diabetic nephropathy. Yeah, thyroid function test. We know that hypothyroidism can cause insulin resistance, loss in blood control. Family history, lifestyle factors, medication history, and then additional symptoms. Ask if the patient has experienced any symptoms such as headache, dizziness, chest pain, shortness of breath. Yeah, so this question can be divided into two. I can, maybe for ClinChem, they can ask you the tests required for this patient or other additional information. Okay. Management. Sorry. Lifestyle modification by weight loss, healthy diet, exercising, smoking cessation, limit alcohol use, blood pressure monitoring. Medication intervention, antihypertensive, lipid lowering agents, Here they are. Statins, niacin, ezetimibe, bile acid binding resins, fibrates, they're quite a lot. Okay. Then remember, manage the diabetes mellitus. Patients are non-diabetic, consider adjusting the dose to ensure drug adherence. So I hope this question is clear for the lipid. It's really quite simple, just interpreting. Okay. Let me see this. A 32-year-old female who underwent surgery for prolactinoma. Thyroxine is 6, which is low. TSH is 0.25. So the T4 is low, so we know that's that is a hypothyroidism, and then TSH is low. So we know the problem is not at the thyroid, but at the anterior. So it is a secondary hypothyroidism. Then another question they ask here is, which other hormone would be necessary to test in such a patient for this 32-year-old female? Any answers in the chat? Which hormone would you test for this 32-year-old female? The question is in the question. The answer is in the question stem. A 32-year-old female who underwent a surgery for prolactinoma. On follow-up, these are the results. So which hormone will you test? Prolactin, exactly. See if the surgery was successful. Yeah. So you check the prolactin levels. Yeah, serum prolactin levels. Okay. Yes, that's clear. Then these are the reference ranges. pH, PCO2. So you can either be given in millimeters mercury or kilopascals. And then pressure of oxygen, HCO3, oxygen saturation. Remember, this is at room temperature. And then base excess, plus minus 2. Then an ion gap, 8 to 12. So these are the reference ranges for the questions that I'm going to ask next. Okay, let's interpret this. Wow, I've already put the answer, but let's interpret it. So you tell me, is the pH high? Is it low? PCO2, PO2, and HCO3. So pH is low. The pH low? 7.2. Yes, pH is low. Interpret. Partial pressure of carbon dioxide. High bicarb. Is the bicarb high? 25. Normal bicarb, low pH, high PCA2. Yeah, so it's a respiratory acidosis. So if you're told reasons, so you'll be told giving reasons, state the metabolic derangement. So you'll say respiratory acidosis, then here are the reasons. Then the causes, I have some causes here, quite a lot. CNS depression related to head injury, G medications, narcotics. So narcotics are the opioids. We know that opioids cause massive respiratory depression, sedatives and anesthetics. Impaired respiratory muscle function, e.g. neuromuscular diseases, neuromuscular blocking drugs such as pneumonia, pneumothorax, pulmonary edema, massive pulmonary embolus, hypoventilation due to chest wall injury. Okay. So this one you have to remember. And it's quite a common question, especially in the MCQs. They ask all the following cause. So they can give you these values and then except. So they can just throw in, they'll give you these choices and then they throw in something like hyperventilation. So the answer is hyperventilation because hyperventilation causes respiratory alkalosis. It's actually the quite high yield one you should know. Okay. I think someone's asking what is base excess? Base excess. I think you mean here. So base excess, how I define it is the difference or the deviation of the base concentration. Okay, so basically what it means is if it's a positive value, it's indicating excess base from the word, so it's an alkalosis. It's a negative value, it's an acidosis. So that's usually the significance of the base excess. Okay. Then for this one, it's an alkalosis. Why? Alkalosis, so HCO3 is normal, the PCO2 is low, and the pH is high. So the pH is high, it's an alkalosis. Then you check, is it respiratory or metabolic? It is respiratory because the PCO2 is low. Causes, hyperventilation, as I said, usually the main intracerebral hemorrhage, salicylate and progesterone drug usage, anxiety, so the liver, sepsis. And then this one, cis-5-year-old male with pulmonary edema, pH is low, so this is an acidosis. The PCO2 is 23, so 35 to 45. So it is low. PO2 is 40, which is, what's the PO2 value? 80, which is very low. And then HCO3 is 15, 22, 28, 15, yeah. So if you are to interpret, so it's a metabolic acidosis. The metabolic acidosis. Which one is lower? Is the HCO3 or the CO2 low? The CO2, our reference is 35 minus 23, which is 12. HCO3 is 15, and the reference is 22. Which one is lower? So is it a respiratory acidosis or a metabolic acidosis? What do you guys think? Huh? What do you think? Is it a metabolic acidosis or a respiratory acidosis? Metabolic, if respiratory CO2 would be high. Yeah, makes sense. So it's a metabolic acidosis. So the low pH, the acidosis, and then HCO3 metabolic, and then the PCO2, the low PCO2 is the compensation. Yeah, so I think it's okay. So it's a partially compensated. Why is it not fully compensated? Because the pH has not gone to normal. If the pH had gone to the normal, which we know is 7.35 to 45, it would have been fully compensated, but this is a partial compensated. Okay. So I hope that one is clear. Confused me for a minute, but yeah, I've understood it. Okay. The following blood gas analysis findings obtained from a 22-year-old female with severe vomiting. Her urine pH was also measured. I think we've done this question, but we can repeat it. What is the acid-base derangement? Give reasons. So we've done this question. So answers in the chat. pH is high. So it has to be an alkalosis. PCO2 is normal. PO2 is normal. HCO3 is high. So it's a metabolic alkalosis, isn't it? Base excess, 9. So we know it's an acidosis, sorry, an alkalosis. Yeah. Give reasons, you'll interpret the way it's interpreted. Metabolic alkalosis, yes. Explain the urine pH result based on the description of how the kidney excretes hydrogen ions. What is the pH? 3.4, very low. The pH is quite low. So account for the low pH. Some explanation, yeah. Any answers in the chat? Okay, let me explain. So, explain the urine pH result based on the description of how the kidney excretes hydrogen ions. Yeah, so these are very, you really have to understand it. Let me see, someone has attempted. Lack hydrogen exchange. Okay. Okay, you have a point, but you have to explain. Okay, let me start. So this patient, look at this patient. The patient is admitted due to severe vomiting. Okay. So one, when vomiting, I have a question for you guys. Does vomiting, before it becomes severe, does vomiting cause an acidosis or an alkalosis? I want you guys, we reason with you guys together. Vomiting, not severe vomiting, just vomiting. What will happen? What acid-base derangement will vomiting cause? Let me see. Someone is saying alkalosis, someone is saying acidosis. So it's an metabolic alkalosis. Yeah, because remember, you're losing the HCl, which is the hydrogen ions, which is the acid. So what will happen is you will have accumulation of the alkaline. Okay. So first of all, this lady, she'll have vomiting. What will happen is you'll have a metabolic alkalosis, as you have said. Okay. So the body will try and compensate for this metabolic alkalosis by secreting bicarb from the kidney. Okay. So the kidney will filter out bicarb. And what will happen is, while we filter out bicarb, remember, we are also retaining hydrogen. Okay. And the fact that we are retaining hydrogen, we're exchanging it with, remember that pump, the hydrogen potassium pump. So we are retaining hydrogen, but we are excreting potassium. So what will happen to the pH of our urine at first after she has vomited? Will our urine be acidic urine or alkaline urine? Someone tell me on the chat if you've understood. Will our urine be acidic or alkaline? Remember, we are we are secreting bicarb and we are exchanging hydrogen with potassium, where we are retaining hydrogen and excreting potassium. So will our urine be acidic or alkaline? Alkaline, perfect, because of the bicarb and the potassium. But now this lady, she has the severe vomiting. So severe vomiting actually is just prolonged vomiting or vomiting over a very long time. So what happens is the body is continuing to compensate by decreasing the bicarb. And you know, when you have prolonged vomiting, remember, you're not only vomiting the stomach contents, the HCl. We'll start now vomiting the intestinal contents from the duodenum and the pancreatic secretions. So these pancreatic secretions include the bicarb. So now we'll start excreting the bicarb. Now what will happen is, as we are continuing to excrete the bicarb from the urine together with the vomit, we'll have something known as hypokalemia. So why is it hypokalemia? Because we are excreting the bicarb and excreting the potassium. So we'll have hypokalemia. Now what happens when you have hypokalemia is, remember that pump. How does the pump work? The pump works by, you pump hydrogen in, potassium out, isn't it? So imagine you don't have potassium to pump out. What will happen is, there's no potassium to be exchanged with hydrogen, isn't it? So what will happen is, the hydrogen now will start be released in the urine. And now when the hydrogen is released in the urine, we'll now have a low urine pH. So that is why our pH is 3.4. I hope you've understood. I've explained how she started initially with the vomiting, how her urine became alkalotic, and then the prolonged vomiting, how her urine became acidotic. Is it clear? For choice number 2? That's how you're supposed to explain. Now summarize it for 1 mark. This question can't be 1 mark. The fact that it's saying explain, it can't be 1 mark. It should be at least 3 marks, because that is it's a lot of words. Okay, let me try and summarize it. So the marking points are, number 1, you have to explain that the initial vomiting will cause a metabolic alkalosis. Now the body will compensate it by secreting bicarb from the urine, isn't it? And then remember, when we're secreting bicarb, we are losing the alkaline, because bicarb is alkaline. That's something you have to remember. Hydrogen is acidic, bicarb is alkaline, potassium is alkaline. Okay. And then another thing, the way it will compensate is, we need more acid. So what will happen is, it will retain hydrogen. And we know that hydrogen potassium pump is, the potassium goes out, the hydrogen comes in. So you'll retain more hydrogen and lose more potassium. And then prolonged vomiting is, you are losing the bicarb in urine, and you're also losing the bicarb in the vomit. And remember, you're also excreting potassium in the urine. So you have hypokalemia. And then because you have hypokalemia, there is no, the potassium hydrogen pump won't work. So what will happen is, hydrogen starts being excreted in the urine, causing acidic urine. Yeah, so the marking points are, number 1, you have to mention the metabolic alkalosis, the compensation mechanism of the bicarb, and the fact that the urine will be alkalotic. You'll also have to mention that the severe vomiting will cause hypokalemia, leading to hydrogen to be released in urine. Yeah, I think that's the summary you give. It's not a must to mention about the pump, but the pump is for you just to understand it. Yeah. Are we clear? So that's number 2. Yeah, this question is about 3 marks. It can't be 1 mark. Explain how we get hypokalemia. I think I've explained it. The more you excrete the potassium, you lead to low potassium levels in blood. List 2 possible causes of this type of acid-base disorder. So causes of a metabolic, what was the derangement? Alkalosis. Give me causes. Give me causes of metabolic alkalosis. Let me see your answers. Causes of metabolic alkalosis, Crohn's disease, diuretics, Cushing's, cystic fibrosis. Yeah, there are quite a lot. We have cystic fibrosis, Crohn's syndrome, Cushing syndrome. Yeah, that's okay. Review this clinical case. Name SWM, age 52 on admission. Takes a 2-week-old child. Presented with anuria for 1 day, refusal to breastfeed for 2 days, diarrhea 1 day. So I think these are the dates. Okay. Okay. Okay, interpret for me this. pH is low. PCO2 is normal. HCO3 is low. So what is this? Metabolic acidosis. Okay. And then on 14th, normal. And then PCO2 is it low? It's low. Then HCO3 is low. What is the derangement on 14th of October? Um, 24th of September, we have seen it's a metabolic acidosis. What about 14th October? pH is normal, so meaning it's a compensated, isn't it? PCO2 is low. You see the answer? I actually don't know. Fully compensated metabolic acidosis. Yeah, so there's a compensation. Yeah, compensation, metabolic acidosis. Yes, so it's okay. It's a metabolic acidosis. Then for the causes of metabolic acidosis. So you have to know all those 4: respiratory alkalosis, respiratory acidosis, metabolic acidosis, metabolic alkalosis. Then you remember for the metabolic, this one you should be knowing. The high anion gap, low anion gap. We have sung this every single day. We have been singing this. So that one I'm sure I know. Taki tu kuandika. Okay. Aya. Okay. The specimen shown was received in the lab with a request for blood gas analysis. Which specimen are used for BGA? Which specimen are used for BGA? See, arterial blood, yes. So arterial specimen, okay. Okay. Which containers are recommended? Which containers do you collect with the BGAs when doing is it red? Is it plain? Heparin, yes. So which color? Which color did you say is the heparin one? Green, excellent, good. Should this sample be accepted? Give reasons. So should this sample be accepted? This one on the red tube. Is this red? I don't know. Can you guys see? Let me expand. Yeah, it looks red to me. No, yeah, give a reason. So wrong collection tube. Wrong collection tube. Wrong color tube. Wrong collection tube. So basically, remember the plain tube. We have no additives. That's why it's known as plain. So what will happen is the blood that you've collected will undergo. It might undergo hemolysis, isn't it? Yeah. We know heparin. Heparin is an anticoagulant, so we want to prevent hemolysis. So arterial specimen, collected site, radial, femoral, brachial, axillary, dorsalis, pedis. We'll talk this one, yes? We have said. Then a cardiac triad screen was done for 73-year-old man. Results are as shown. CKMB 2.2, which is normal. Myoglobin way high, 358. Troponin I less than 0.05, which is normal. So, okay, interpret. First of all, you'll be told interpret it, then give a diagnosis for this 73-year-old man. Acute myocardial infarction, good. That's one of the differentials. The reason, so the myoglobin has raised, and you remember from our chart, myoglobin was the first to be raised between hour 1 to 4, isn't it? Yes, it's an early myocardial infarction. Here, which other one? Any other differential? Remember, it can also be a reinfarct. So let's see. This is an acute myocardial infarct or a possible infarct after the CKMB and troponin I levels returned to normal. Okay. Or a reinfarct. Okay. Yes, good. That's good. Then this is another one. Biochemistry results for a 57-year-old hypertensive man admitted with a diagnosis of COVID-19. ALT, this actually came in our exam, if you guys can remember the exact question. ALT, 54, ST, 208, LDH, 582, total CK, 469, which is high, CKMB, 26, which is high, troponin I, 18, high, NT-proBNP, 1995, 1995. So this marker has already given out. So what is the diagnosis? Let's give the diagnosis. Everything is high. Yeah, everything is high. But what is the most obvious diagnosis? I'll give you a hint. The NT-proBNP gave you heart failure. Heart failure. Yes, heart failure. Heart failure secondary to acute myocardial infarction. Which one comes first? Heart failure or acute myocardial infarction? Or do they come separately? So this guy had an AMI because of right-sided heart failure, secondary to liver disease. Yeah, it might be secondary to liver disease because look at the STLT ratios. Most likely it's an alcoholic one because the STLT ratio is greater than 1. Yeah, so let's see the answer. Oh, before I show you the answer, tests should be done in this 57-year-old hypertensive man. Quite a lot. They usually ask 3. Name 3 tests to be done in this man. Yeah, you can be very as vague as possible. So many tests. Let's see. Let's see the answers. Number 1, lipid profile. Yes. What do you expect? We'll expect in this patient maybe to have elevated lipid levels, elevated, so hyperlipidemia. Another test, we need 3 tests. Renal function test. So, yeah, so renal function test, I hope you mean the UECs, urea, electrolyte, and creatinine. We'll expect the creatinine to be high in this patient, isn't it? Electrolytes, before you mention any other test, okay, let's start with sodium. For sodium, what do we expect the sodium to be? Should it be high? Should it be low? Should it be normal? For this patient? Someone is saying hyper, someone is saying hypo. Hypo. So basically it depends. Yeah, let's see. So electrolyte levels, sodium should be normal or decreased. Hyponatremia can indicate a poor prognosis. Since this patient has a heart failure. Which other tests? So we have CBC, serum, screen for anemia and or an infection. Creatinine, so the UECs, normal or high. And then glucose, so remember diabetes, to screen for diabetes. LFTs that we already did, so don't need to mention, but LFTs, inflammatory markers, so raised CRP, indicate an acute infection. Then lipid studies, elevated cholesterol, hyperlipidemia, TSH levels, possibly lowered as a sign of hyperthyroidism. So basically, these are the lab studies seen in a patient with heart failure. Okay. Yeah, you can also do some other cardiac biomarkers. So if you've done NT-proBNP, I think that's enough. Troponin I, we already did. CKMB, we did for the AMI. Yeah, that's okay. Okay. And then I think this is my last question. A 68-year-old man comes to the physician for a follow-up examination. He has chronic kidney disease. Identify 3 risk factors for the above. Chronic kidney disease, risk factors. TM, HTN. Oh, wow. Diabetes mellitus. Yes, diabetes mellitus, hypertension. Which other one? Yes, a history of acute kidney injury is a risk factor. Glomerulonephritis is a risk factors. Let's see the answers. Diabetes, hypertension, obesity, advanced age greater than 60. You see, this man is 68. Smoking, alcohol. Remember, I told you for any disease, and they ask risk factors, smoking should be one of the risk factors because smoking is an etiology for so many things, so many things. So in case you have any problem remembering any risk factors, just write smoking. You won't go wrong with smoking. Okay. Then a family history of CKD, even family history and smoking. If you ask risk factors of hypertension, family history of risk of hypertension, risk factors of hyperlipidemia, risk factors of liver failure, family history, smoking, all of them. They are good answers. I've seen someone has joked, except risk factors of ulcerative colitis. Yeah, we know ulcerative colitis is the vice versa. We know smoking is a risk factor for Crohn's and not a risk factor for ulcerative colitis. It is actually preventative. Yeah, that's a nice one. Yeah. Mention 3 clinical features of the above patient or patient with chronic kidney disease. Yes. Repeat kindly. What do I repeat? Risk factors. Repeat kindly. The risk factors. Here they are: diabetes, hypertension, obesity. Or if you're told to any question in risk factors, just mention smoking and family history. Oh, the question. Mention 3 clinical features of the above patient. The above patient may present with. Yes, our patient has CKD. Clinical features of CKD, there are quite a lot, so I'm expecting a lot of answers. Oliguria, good. Low oliguria, low urine output, good. Hematuria, yes. So presence of RBCs in blood. Edema, yes. And remember, the edema is the peripheral one. So we'll have the edema under the legs. Anemia symptoms due to kidneys not producing EPO. Excellent. Remember, the kidney is not producing erythropoietin. So what will happen is you'll have symptoms of anemia. So you have to mention them: the fatigue, the pallor, easy fatigability, those ones, quite a lot. Anemia, pruritus, yes. Asterisks, I don't know what that is. What is Acidosis? Acidosis. Oh, tremor. It's known as flapping tremor. Yes, there. That's also there. Yeah, tremor, flapping tremor. Yes. So let me expand this image. Acidosis. Oh, it's actually even here. Seizures, somnolence, coma, fatigue, weakness, headache, nausea, vomiting, loss of appetite, uremic factor, pulmonary edema, uremic pericarditis, pleuritis, decreased urine output, uritis, color changes, hyperpigmentation, pallor, hypertension, paresthesia. They can actually ask you name, so that it's not general. They can give you a question. Name 3 clinical features that manifest in the kidney or nephrological symptoms. I don't know, something like that. So decreased urine output, albuminuria, hematuria, paresthesia, then EPOs, anemia, increased risk of infection, increased risk of bleeding, peripheral edema, you know. Oh, yeah, it is a very good image. Okay. I hope that's clear. Then they can ask you the lab findings, increased creatinine and BUN. Do you know how we diagnose CKD? Who knows how we diagnose CKD? How do we diagnose CKD? Dr. Walong taught this. How do we diagnose CKD? Let me see. GFR, yes. So what happens to the GFR? The glomerular filtration rate should be a decrease. But to a certain level, because you can remember that chart. There's a chart he sent, the KDIGO. I don't know whether I can have it. Check on my end. The KDIGO. If you remember the GFR, when we were diagnosing, what I remember is GFR of less than 15 is actually kidney failure. That I can remember that because it was very significant. A GFR of less than 15 was kidney failure. But remember that the GFR should be decreased. And then the creatinine and the basic, the blood urea nitrogen are increased. Hyperkalemia, metabolic acidosis, decreased HB, but a normal MCV because it is no more chronic. Okay. Okay, this one. Okay. Comment on the serum finding of PTH, calcium, phosphorus, and vitamin D. Now, this one you have to understand. You just can't just comment. You have to understand. So let me see your answers. Okay, you can guess if you want, but you have to understand. This is a very high-end topic. Very, very high-end. Comment on the serum findings of PTH, calcium, phosphorus, and vitamin D. You can guess and write everything increases. I mean, you have a 50% chance of getting, but I want to see if you've understood. I want you to see. So comment. Okay. Hypocalcemia. So calcium, let's write it down. Calcium decreased. Vitamin D decreased. PTH increased. Mebakia gani? Phosphorus. Phosphorus. Phosphate, raised phosphate. Okay. Now, let me explain. First, let's see the answers. PTH and phosphorus increased. Calcium and vitamin D decreased. Okay. You can cram, but let me explain. Aya. So, okay. The first thing you have to know is which one is the firstly affected? Vitamin D, isn't it? So we know chronic kidney disease, your kidney is not functioning well. So what will happen is you'll have a deficiency in vitamin D due to the decrease in, there's an enzyme used in the conversion of vitamin D to its active form, the 1-alpha hydroxylase activity. You'll have a decrease in that. And when you have a decrease or a deficiency in vitamin D, what will happen is, we know the function of vitamin D is to increase the reabsorption of calcium in the small intestines, to move calcium from the bone to the blood. So vitamin D is usually activated in the response of hypocalcemia. So what will happen is, if you have low vitamin D, what will happen to the calcium? You'll reduce absorption of calcium. So what will happen is, you'll have low calcium or hypocalcemia. So that is why calcium and vitamin D is decreased. Now, let's talk about PTH. Now, PTH, what is the function of PTH? PTH is usually secreted in response to low calcium. So what will happen is PTH will increase. So that's why in CKD, I'm sure you've seen this in an MCQ, we usually answer that the PTH will have something known as secondary hyperparathyroidism. So it is usually caused by chronic kidney disease. Okay, remember that. Secondary hyperparathyroidism. Okay, and what will happen is PTH. So how does PTH work? We know PTH works by it will secrete, it will cause the kidney to absorb more calcium. And in the process, what will happen is there'll be excretion of phosphate. That's how it works. It absorbs calcium and phosphate is excreted. But now, remember, this is CKD, so we have chronic kidney damage. So what will happen is the kidney is not working. So you'll have increased the PTH, but now the excretion of phosphate is impaired. So what will happen is you'll have hyperphosphatemia. So that is why the phosphorus will be increased. Okay. I hope you've understood this concept. Very high yield on calcium metabolism. It can also come in an essay. You have to understand the function of PTH, phosphate, calcium, and vitamin D and their relation. I've tried to explain it, and yes, that's how it is. Okay. Any question there? Yeah, the last one. Mention and comment other lab studies that should be done for this patient. So creatinine levels, we've said they'll be raised. BUN, they'll be raised. Glomerular filtration rate, we said it will be decreased. Urine dipstick, we may show hematuria or proteinuria. And then urine microscopy, we'll see casts, the waxy casts. Okay, which metabolic derangement do you expect for such a patient? So we know that this one, you know, it will be higher iron gap, metabolic acidosis. I think we had said, I think I have a chart here. Basically, these are the levels and then the mud piles, or you can use the ladder. There are quite a lot of formulas. So where does here fall? It falls under uremia, isn't it? So that's why it's a high anion gap, greater than 12. And then the normal anion gap, here it is. I think with that, I'm done. Unless you have a question. Can stop sharing.